Thank you. My name is Ayush Balaji. I'm a third-year medical student at the Hull York Medical School, and I'll be presenting about heterotopic cardiac transplantation in patients with univentricular pump failure. I have no declarations. So I'm just going to start off with a quick maths equation. So 1/2 plus 1/2 makes a full. So this is the premise that we've built our paper upon. So I would like you to keep that in mind throughout this discussion. So the problem is, at present, the availability of donor hearts is becoming increasingly scarce. And with the current guidelines, numerous hearts that are available are deemed unsuitable and discarded because of their insuitability for standard orthotopic transplantation. And transplant is still the destination therapy for patients who have single-sided ventricular dysfunction, be it children or adults. So to combat this problem, we propose the use of heterotopic cardiac transplantation for pediatric and adult patients with univentricular dysfunction. So what makes our concept unique? We propose to completely split the circulations, pulmonary and aortic, so one heart per circulation, one heart for the lungs, one heart for the systemic circulation. And we propose to use the donor hearts, which have intact single ventricular function, so a heart which has isolated left-sided failure or isolated right-sided failure as a heart to support the biventricular function. And we propose to use it in congenital cardiac patients with univentricular physiologies as well, and we hope that it will enhance domino transplant capabilities. Here's a schematic representation and an overview of what this could look like. Basically, all right-sided structures are connected to the right side. So cavo-cavo anastomosis and a PA-PA anastomosis, and you close the right side on the native. Or on the other side, you do a pulmonary vein to LA anastomosis and an aorta to aorta anastomosis and close the left side. Here's a drawing of the techniques. And in terms of the left side, we've also explored the use of an explantation implant technique where we implant the donor heart in a dextrocardiac position. So here's a 3D rendering of the donor heart as a pulmonary ventricle. As you can see, there's been a cavo anastomosis, as well as a shunt to perfuse the coronaries. And here's a 3D rendering of the donor heart as a pulmonary ventricle. So you can see there's been a pulmonary vein to left atrial anastomosis, as well as an aorta to aorta anastomosis. Yeah. And here's the result of an ex vivo operative technique that we've done on a porcine model. Again, this is a conceptual study, and we hope to use this to build on as a premise. Some of the considerations that we have to take into place are intrathoracic space, coronary perfusion, and cannulation strategies, as well as synchrony of both the hearts. In terms of intrathoracic space, landmark papers by people like Christian Barnard have suggested that opening the pleura and mobilizing the hilum can actually help combat this. In conclusion, by splitting the circulations, we can use hearts that were deemed unsuitable for standard orthotopic transplantation to support biventricular flow in patients who would have not been candidates for transplant in the first place. And in terms of the pediatric population, we hope that this can be an alternative to the passive flow Fontan procedure. You can check out some of our 3D printed models as well as a virtual reality rendering of the heterotopic transplantation after the session if you would like. We have them here. Thank you very much.
Yeah, thank you very much. It's rather short to really see the surgical procedures, but very interesting idea. So you did this in animal ex vivo thus far, huh?
Yeah.
Not in vivo.
So we're trying to apply for ethical approval to go through the in vivo process, and we want to do some basic tissue level studies to understand the myocardial requirement for oxygen in order to determine coronary strategies.
Yeah, and what exactly do you mean with domino? You mean?
So if we say a patient who is suitable for an orthotopic transplantation gets a heart, their heart that's been explanted because they've had, for example, left side or right sided failure, can then be used as a heterotopic transplant, so a forward chain. So we take hearts from patients who may have isolated left or right sided dysfunction and use it as a half heart for another patient.
Oh, okay. Okay. Yeah, please.
My name is Anastasia Pavlikova-Chertovska. I'm a cardiac surgeon from Ukraine. I have a little question about what is the coronary perfusion strategy for this second pulmonary heart?
So in terms of the actual coronary arterial perfusion, we've come up with a few different strategies, including grafting from the native aorta to the aortic stump of the pulmonary heart. But we've also been exploring the use of pedicled grafts, or in the pediatric population, when you have a Blalock, Thomas Taussig, or systemic to pulmonary shunt, we take down the distal end and we anastomose that to the root of the donor heart. And we're also at the moment exploring the use of an atrial septostomy, because you have an offloaded donor heart, so the myocardial oxygen requirements are in theory going to be less, so may not require the same saturations.
Thank you.
I mean, this is amazing. So really impressive. So you're feeling, so with this chance surgically, we may increase the rate of transplantation, or even we may decrease the need of MCS for isolated RV and LV dysfunction. We do perform abdominal transplantation and so on, but not with this setting, of course. Which kind in vivo of matching in terms of sizing, BSA, you would play with such kind of patients? Because you may play even with really small hearts and use their isolated functioning on LV or RV. Which is your feeling, or you do need other characteristics in vivo?
So we've read quite a few papers from the literature of the standard heterotopic transplant method, where the actual size of the donor heart makes a large difference, and there's proposed algorithms for how you should select the donor hearts based on the feasibility of the thoracic space, the patient's body surface area. However, in this use case specifically, we think that because we're using a heart which has already been offloaded and we're using only one side of the heart, we can slightly modify these guidelines because you only have flow through one of the ventricles. And in terms of which of these procedures are more feasible, we think using a donor heart as a right-sided assist is more realistic in the next few years, as opposed to using a donor heart as a left-sided assist due to the complexity of the technique.
Okay, well, thank you very much again,
Thank
and
you.
congratulations for your presentation as a medical student.
Thank you.